the next interview is with Dr. John DiPersio. Dr. DiPersio is head of the Division of Oncology at Washington University and the Deputy Director of the Siteman Cancer Center. Can you say something about what you do, how you spend your days, what your job is like?
Yeah, so my day, Dan, is mixed between administration, clinical care, and basic research. And I would say that most days I have a mixture of either some basic science and some clinical care with a little bit of administrative effort sprinkled in, or primarily focused on clinical care or basic research. I try to keep the administrative responsibilities somewhat focused, and I try to delegate as much as I can to other people that know a lot more about administrating than I do, even though I'm the chief of the division. So I think that's a lesson I learned a long time ago.
So I think you're the only person who's leading a large academic unit the way you do. How big is your division?
We have 145 faculty and about 1,500 employees. So it's a big operation.
It sounds like it's hard to limit your administrative activities. How do you do that? Do you have a business manager and deputy kind of directors, people that help you run the various areas in the service?
Yeah, so it's just like you would organize any kind of business where you have a series of leaders in the division, faculty leaders, and also administrative leaders that are overseeing various groups of people. And there is a ladder that you climb up to, and so most of the section heads oversee various sections like medical oncology or transplant and leukemia, or molecular oncology, computational biology. Each one of those groups of faculty have administrative and leaders that are overseeing those groups, and they all report through a series of leaders up to me. So I really try to be as hands-off as possible and let them make a lot of the decisions. And I'm really more interested actually in the big picture issues, and that can get me into trouble from time to time. But I think for my quality of life, it's really made a huge positive impact to relegate and delegate responsibilities to others that you trust, that view you as someone who they can go to bounce their ideas off, and not someone that just takes orders from me. So I like that, and they like that. And I think, if you think about your own situation, when you're in a setting where people are controlling your life, it's less fun and less engaging than if you have some flexibility on your own to make decisions. So, and in the end, the decisions are always a consultation between people at different levels, and ultimately we finally get to the right direction in the end.
How did you end up doing what you're doing? What maybe starting with medical school forward? How did your career path take you to where you are now?
Yeah. So when I was in college, I wanted to be an astronaut, but I was interested in physics and astronomy, and I really was very interested in astronomy and flight and space flight. And I thought that it would be, I didn't know anything about it. I thought, well, I could be a pilot and an astronaut and a physicist. So obviously it can't be all those things. And so fortunately or unfortunately, I played hockey in college, and I played collegiate hockey, and I lost my left eye. And then that did my career in for an astronaut or a pilot. So I decided to go to plan B, and plan B for me was science, and I really liked medicine, and I liked the fact that science was integrated into medicine, and I liked certain parts of medicine where the science was well integrated, and so that's why I went into medicine, and that's why I went into hematology oncology, because when I trained, I think probably more than any other discipline, the basic science of some of these diseases was probably better worked out in hematology oncology than almost any other area of medicine. And also, we could I could potentially envision interventions that might make a difference. And so for that, my whole life, I've really been interested in, been interested in science that has translational impact or potential, and then therapeutic impact. That's for me, the science is less interesting unless I can see an endpoint or a translational direction to it, and some kind of way of getting it into the clinic. So it was always, everything I've always done has been with that view and slant. So I'm less interested in something that's incredibly fundamental, and that's it. I am interested in fundamental things, but I'm interested in them as they relate to how I could bring that forward into the clinic. That's the thing that really is the best part of medicine for me. And then when you've actually take care of a patient and you actually see how an idea that you had gets developed, and then you actually are in a position to treat a patient with an idea that you've had something to do with, I think that's the best part of medicine, because then you can see that, geez, it's like learning anatomy. You have no idea why the hell you learned all those anatomical structures until you're actually in the operating room and you realize, oh, this is why I learned where the trapezius innervates or whatever.
So you were in an MSTP program at Rochester, is that right?
Yeah.
Yeah. So how did you then decide how you're going to select your residency and your fellowship training and so on? Was that intentional? Was it a very well thought out process?
Yeah, no, there's partially intentional and partially just pure chaos and randomness, or entropy. But I can tell you, I was in the MSTP program, Dan, but I didn't initially start there. I entered, so I went to medical school, and this is what happened. My roommate was an MSTP student, and I was really enjoying the science of medical school a lot. And then when we had to, in the third year, go into the clinic, I had an epiphany the morning of the third year of medical school. And I sat down with my roommate, who was then going into the lab, and I said, I think I really want to do that. So I did it in an odd way. And then I went to the head of the graduate school, and I was in the second starting class in the MSTP program where I went to medical school. And I said, can you fit me in? And of course, there were only a few MSTP students, not like it is here at Washington University. And they said, sure. And so I did my first day as a third-year clerk, and my second day I was in the lab. That's how it happened. And then when I finished, I had worked in a lab that was focused on hematology oncology, because I had already sort of liked that area. And then, then I really focused on trying to go to the places that I thought would give me good training. And that was, I looked around and I went to the place I was most attracted to that I thought would give me a good training. And that was UT Southwestern. And then I went to UCLA for my fellowship.
So one of the things that I've noticed over the years is that because of the length of training, it's hard to get MSTPs to become chief residents. They see it as an extra year. What made you decide to be one of Don Selden's last chief residents?
Don Selden and the threat that he would kill me if I didn't do it. When Don puts his hand on your shoulder and says, John, I've got my eye on you. I think you'd be a great chief resident. Of course, at that point, you're melting in front of him, and you'd say to him, whatever you think, Don, I'll do whatever you want. It's not like today where kids think about their future and their salary and when they can finish. And for me, in those days, it was just such an honor. And plus, I had another co-chief resident. In those days, there are lots of chief residents now. In those days, there were only two. And I was one of them. And the other chief resident is now chairman of medicine at Northwestern. And he was one of my best friends. And so the other incentive was that I was going to be working with a good colleague that I not only admired and respected, but I also personally liked. And I thought it would be a wonderful year and we could do a lot of great things. And we did. And it was a great year. It's a fantastic year being a chief resident, I think. it's just different, I think, than being a resident, because you start developing some leadership skills and administrative responsibilities that that I think set you on a path in a different direction for many of us.
So then how did you happen to settle on UCLA for your fellowship? What was it that attracted you to that particular
Yeah,
institution?
so UCLA had a great heme-onc program at the time, and a lot of sort of the giants in the field were there. And I interviewed at the Hutch, the Farber, UCLA, and UCSF. And of those places, you know, they were all really good, but UCLA was particularly attractive to me because the people that were there were doing really, I thought, cutting edge research. It was also a different area of the country for me. I really liked the notion of going someplace new, and I'm born and raised in Boston. So I felt like I would be regressing in a way, going back to where I was born with a lot of my friends. And I wanted to do something new, and I wanted to be in a new place. And, you know, I was excited about living in Southern California because I had never lived there. So there were a combination of, and there were lots of great institutions in Southern California, in San Diego, and we collaborated with lots of people in UCSD and Scripps and UCLA, and it was a lot of fun living there too. I lived on Venice Beach.
Oh my goodness. Yeah.
Yeah,
Did you,
right
did
on the
you,
beach.
did you lift weights down on the?
No, I didn't lift weights, but I lived right on the beach, right on the beach. My window looked right out on the ocean. Yeah.
So are you familiar with the novels of Robert Crace? He writes
No.
about Elvis Cole and Joe Pike, and he writes about Los Angeles. You know, they're all set in Los Angeles, and in one of the novels, it talks about the fact that Venice, you know, Beach was literally developed by a developer to be modeled after Venice. You know, with the little
Yeah,
canals and so on.
yeah.
Which I was unaware of.
Albert Kinney.
Is that his name?
Yeah, he was the architect that built Venice Beach in like Venice. And I lived actually. After I finished my training, I bought a house, my first house that I ever owned, right on the oldest canal in Venice. It's paved over now. It's called Market Street, and it's right in the heart of Venice. And so I lived initially right on the beach, and then I bought my first house 1 block away from the beach on Market Street. And
That was the
Grand Canal in
those
Venice.
little small vertical houses, kind of,
Yeah.
you know, yeah. What did you pay for it? I just out of curiosity. Do you recall?
Oh, I can tell you exactly. I paid at the time, I was moonlighting quite a bit. I paid, and I had a significant other who was employed as a lawyer. And we bought it together. It was $450,000 in 1984.
I think they're worth a couple million now.
Yeah, and 2 years after, a year or two after I bought it, someone knocked on my door, and he was 23, 22 years old. And he had a 35-year-old girlfriend in his Mercedes convertible. And he said, "I want to buy your house. I like your house. I want to buy it." And I said, "It's not for sale." And he said, "Well, how much did you buy it for?" And I said, $450,000. He said, "I'll pay you $1 million." And I'm thinking to myself, okay, in 2 years, I've just made $500,000. So if I keep it another 2 to 4 years, I'll make a couple of $1 million. So I told him to shove off. And then 2 years later, the market crashed, and I lost everything and had to sell it for a loss.
Well, you wouldn't sell it if you kept it. You wouldn't be selling it for a loss now.
If I kept it, it's a historic house in Venice too. It was one of the old historic houses in Venice.
So how did you pick your first faculty job? What factors did you consider as you were deciding where to go for your first faculty
So
job?
when I finished my fellowship, I did my postdoc with Judy Gasson, who was a terrific mentor. And I was hired as an assistant instructor, and then as an assistant professor. And I was doing well, but I had work that was overlapping with other people in the division. So my previous division chief was very supportive, but he went to be the director at Memorial Sloan Kettering, and the second guy in control didn't feel like I was adding that much additional scientific dimension to the division. And so I knew that I wasn't going to be able to get space and what I needed there. And so I started looking, and I looked at a few institutions. I looked at UCSD. Ajit Varki, in fact, was the guy. I don't know if you remember Ajit, very good friend of Phil Majerus,
Yep.
trained here at WashU. He was recruiting me at UCSD, and then MD Anderson, UNC, Lineberger, and the Farber. And so I looked around, and then at the very last minute, a call came from Marshall Lishman, who was the previous president of ASH and was the head of Hem-Onc at Rochester, where I did my training. And he said, we were looking for a new director of the bone marrow transplant program. And I said, gee, I'm just finishing up. I've just been a faculty member for a couple of years. I don't think I'm ready to be a director of anything. He said, no, you can do this. It'll be fun. You can, and so in the end, they made it really appealing. And so I went and took the job. And then after that, I spent about 3.5 or 4 years there. And I then was recruited here by Stan Korsmeyer and Tim Lay.
So when in your clinical training at UCLA, did you train as a bone marrow transplant specialist, or did you have to learn that on the fly when you got back to Rochester?
Yeah, so that was one of the reasons why I went there. Along with the Hutch and the Farber, there was a pretty good sized transplant program at UCLA. Marty Klein and Bob Gale and those characters, Dick Champlin. So they had a lot of really sort of well-known transplant experts, and that's was what I was interested in, leukemia and transplant. So as part of my training, it's not like today, I trained really, don't tell anybody, but I just did 1 year of clinical training. And then I went right into the lab, but I was able to sit for both boards. And I had a continuity clinic, but that's all I did. And I didn't do any other training. So I eventually got boarded in both oncology and hematology. But my 1 year of training at UCLA was heavily slanted towards transplant and leukemia care, because that's just what they did there. So it was.
Excuse me. It's interesting and hard for kids now to understand, but things were much looser back then. I think Edbenz's total clinical training was approximately 0 years in hematology and oncology. Before he became head of hematology at Yale, he sort of became a faculty member and a fellow simultaneously. And his work at the NIH was all basically doing molecular genetics in French Anderson's lab. So, Ed, was, spectacular, I think, division chief and later a chair, and head of Dana-Farber, had exceedingly little clinical training, and people would tailor training to people's different levels of ability, I think, in a way that just doesn't happen now.
Yeah, it doesn't happen now, exactly.
So what made you came to WashU? I as an outsider, I would have said, as an outsider to the division, I thought that bone marrow transplantation at WashU was pretty terrible before you came. What made you decide to come into this sort of wilderness and leave Rochester?
So when Stan called me, he said that we're looking for to recruit some people into hematology oncology, and so I visited, and I found exactly what you were saying, that there was a large hematology group that was just doing research, and there were only 4 other faculty that were seeing patients outside of hematology. And there was only one hematologist that saw patients. So if you can imagine this big place with only 5 clinical people, 1 clinical person on the heme side, that was Maury Blinder. And then on the onc side, there were only 4 people. That's it. And I was the 5th person. And after I came here, Nancy Bartlett came. So it was quite minimal. And we were seeing 300, maybe 250 to 300 new patients a year. Maybe the whole staff was maybe 15 to 20 people. And that was it. The transplant program was doing almost nothing, maybe 10 transplants a year. The transplant programs weren't huge generally at that time, but in Rochester, we were doing, when I left there, we were probably doing 150 transplants a year, 125 transplants a year. So I came here, and the reason I really came here was because, or looked, was because it was leaving Rochester to go to WashU, and I felt that the opportunities to, and I was a little bit struggling in the lab. You know, when I went to Rochester, you know, when I was at UCLA, I had all these people around me and it was a great environment. And I went to Rochester and I set up my own lab. They gave me a little bit of startup, and I was put completely by myself. And I really, in an area where I couldn't interact with anybody else. And I was doing research that wasn't really related to anybody else in the division. It was a relatively small division. So within a year, I started getting a little bit worried. You know, I was submitting some grants and I wasn't getting funded. There wasn't many people I could talk to. My mentor, Marshall, worked in a different area. He was very supportive. He was a fantastic guy, but he's very misaligned with my scientific interests, and I couldn't find sort of the, you know, this group to interact with. And after the second year, I said, gee, I'm going to be in trouble if things don't turn around. And I really wanted my lab to succeed, and I really wanted to get funding, and I wanted to be a successful independent investigator. And the clinical program there was great. It was very satisfying, and everybody was working like a great team. And so I realized after the third year that I would have to make some kind of change. I would either have to move my lab, and I couldn't find space. They wouldn't find me additional space with other people. And so, and there was really nobody there to collaborate with. And so when Stan called, I said, gee, maybe I should look. And when I came here, I was just struck by all the really good scientists, and everybody was doing great things, and incredibly dynamic environment. And it's like one of these things, two things just appeared out of nowhere in my mind. I felt like this is a huge hospital in place, and there was no oncology going on here, almost none, zero. And so I said, I can do this. Even if I was brain dead, I could build up oncology here. So the worries about being able to navigate a complicated clinical program and building a clinical program, I had less worries about that. I knew how to do it. And I knew that in this setting that all these people live around here in the region, and also the collaborative environment here, I could do this. So that was not, I was kind of looking forward to being able to do that. But the scientific you know, opportunities seemed really, they looked like they might save my life. You know, being around Stan and being around Tim and all the people that Tim was training, and the people in hematology and the institution in general, the immunologists here. I said, geez, I mean, I could maybe pull my career out of my, you know what, and save it by, you know, this move. And so it was a very hard decision, because I had lots of great friends and colleagues in Rochester, but and John Atkinson was the driving force for me coming here. And, you know, ever since I've been here, you know, I've had, especially in the formative years during the expansion phase, and maybe this is a lesson for everybody, when you move, you look at your environment carefully. Clinical, you know, your success and your happiness and your quality of life is so largely dependent upon all the people you interact with. You can do stuff on your own, but eventually it gets hard to do stuff on your own, because science moves so fast. You need people to help you with new things. You know, the clinical, you know, approach to these complicated diseases moves so fast. You really need other people to fill you in on how to stay up to snuff and all this stuff. And so it's really important to find environments that are collaborative, team focused, while you can focus on your own independent stuff, but you can use the help of everybody around you. So, and then for the science, I said, well, this is the greatest opportunity. If I, you know, if I make this move, I'm going to give myself the best chance to succeed scientifically. And I think it worked for me.
Yeah, I think you touched on an area which I think, you know, what young people don't necessarily understand or appreciate, which is that if you're a scientist that requires collaboration with other scientists, it's important to go into the right kind of environment. A friend from medical school is a physician scientist who trained at a world-class pulmonary division and then took a job at a world-class medical center with a lousy pulmonary division. And nobody was doing the kind of science he was. And as a result, his career really struggled, for a number of years because he was just basically in the wrong environment for him. He was a high quality person doing high quality science, but with no easily identifiable collaborators. So,
yeah, so I would say that, that's the way it was for me, but I can see how the same themes emerge from any kid going into any kind of practice, internal medicine, whatever subspecialty internal medicine, private practice versus academics, an academic private practice, or a clinical academic practice. The same thing applies, and that is don't be by yourself. Don't go to places where you're kind of by yourself. That's ultimately, you lose perspective on the world of medicine. And it's the greatest part of being around other people is they teach you the best part of going to being the attending on service for me is that even though I don't admit it, every day the residents and the fellows are teaching me things. I listen to what they say. I learn a ton of stuff. Of course, I teach them too, but it's the joy of teaching, and it's the joy of learning, and the joy of interacting. That's the best part of these practice opportunities. If you're in private practice and you're doing general internal medicine, I think you probably do better if you're around a few smart people, where there's occasionally a young person coming into the practice, and there's some one or two really senior pontificators around. You get the whole deal, and you can interact, and you can think together and work together and help each other out, plan things that are new together. You can do a lot of things in a general internal medicine practice which are quite innovative and quite transformative and have impact on patients' care. And when you're by yourself, it's really hard to dream that stuff up. But when you're interacting with people that have different perspectives on things, and certainly it's the case in an academic center where you're just around all these really smart people and smart trainees, it's really the best part of what I do, really. I love doing the research and writing the papers and all this stuff, but to interact with these people that are sort of thinking differently than me, that's what makes it really great, I think.
so trainees today all want to know something about work-life balance, and we probably both grew up in a time when work-life balance was work, and I would say that as somebody who watched from a distance, it appeared to me that you were a relatively unusual academic physician, in the sense that you were a physician scientist running a lab and doing fundamental science, but were also extraordinarily active as a clinician. You attended frequently on the bone marrow transplant service, which is a very high intensity service with lots of sick patients and lots of crises and so on. Looking back on it, do you have any thoughts about how you managed your life in terms of your personal life and your work life and so on that you'd care to talk to trainees about?
Yeah, I don't think I would do what I did. I did exactly what you said, and I ended up being alone until I was 50. And so I wasn't married and didn't have really a significant other. I had lots of friends, and I was as social as I possibly could be. But, I think that I didn't have a family until I was in my 50s. And so it is, and I couldn't imagine the amount of time I was spending in the lab and in the clinic. I couldn't imagine that I would have a minute for a family. And so, and so it seemed to be perfect for me until I met somebody and had a family. And then I realized that, that's, that's pretty important, and not only pretty important, but it's a lot more fun than a lot of the other things I was doing. And so I missed out on a lot of years of really particularly high quality living, if you will, by just focusing on, you know, in a really monocular way on just killing myself for years, thinking that, you know, that not that I would be a better person, but I'd make extraordinary impact on others primarily. And the reality is that, you know, you can do just as much if you balance your life. I do just as much now with a couple of kids and a great wife and a much more diverse life than I did when I was by myself, just doing research and seeing patients all the time. I mean, I would be embarrassed to tell you how I lived my life for, you know, the first 15 or 17 years I was here. I mean, nobody would believe it. But for me, it was like, it was just my raison d'etre. You know, I just was blind to everything else on the planet until I met a significant other and got a family. Especially when you get a family, it's like, what was I thinking? You know, what was I thinking? You know, and I do think that you can go overboard in the other direction, and that you can, you know, lose sight of the great joys and importance of what you're doing in your job by, you know, by not working hard. But I think that, you know, I did it probably the wrong way, and I wouldn't recommend anybody else do it that way.
Well, I appreciate you taking the time to talk to me, and by extension, the trainees that'll be looking at this. Have I neglected to ask anything important that you think you know, people should hear?
Yeah, I think the only thing that I would say is that, you know, um, for all the trainees out there, I want to quote you what Don Selden, the famous probably most famous chairman of medicine ever in any department of medicine at UT Southwestern. He started, you know, in fact, you know, when I came here, I always thought about Don Selden when he started that incredible department of medicine in an army barracks in Dallas, where there were just a few people, and he grew it from nothing himself. And he was the one that saw every new patient for years and years and years. And so I had that in the back of my mind because I was his last chief resident before he stepped down as chairman. And I said, you know, when I come here, I got to do the same thing. I got to work completely just day and night. I got to keep my lab going. I got to see every patient. I got to, you know, round on 60 patients a day and kill myself to build this thing, just like Don did, you know. And so he used to say to me, you know, the best doctor in the world or the worst doctor in the world makes a difference only 10% of the time. And if you don't turn out to be the best doctor in the world, I'll come back from my grave and kill you.
Yeah,
That's true, because I mean, that's the thing about it. So my recommendation to all the trainees is whatever you do, be the best doctor in the world. It takes effort, and think about where you're going to go and who you're going to be around. And when you get there, put an incredible effort into it, but also try to maintain a little bit of a balance with your family. But you know, you can get by not being the best doctor in the world, and that's not what you should do. You should be the best doctor in the world, or I'll come back from my grave and kill you.
all right. I appreciate it.